My name is Manesh Patel. I'm from Duke University. I'm joined by a friend and a colleague, Amit Khera, who's a prevention cardiologist at UT Southwestern. Amit, thanks for joining me.
Well, Manesh, what a great meeting. We're excited to talk about all the great science.
Yeah, it's great just to be back at meetings. I know it's several years since COVID, but it's really great to be in person. And, the cardiovascular field keeps evolving. The science is getting quite amazing. And maybe we kick it off. We're going to do about 7 studies here in the next 8 to 10 minutes and hopefully give everybody a bit of the flavor of the science that we got to see. So, Amit, you want to kick us off with Warrior? I think that was one of the first, if not the first late-breaking clinical trial.
For sure. And as you know, that was in that first session. We'll talk about a lot in the first session. I also want to just pick up what you just said. You and I were planning during COVID for meetings, and it was hard. And it's so great to see the vibrancy of meetings again. And congratulations to the ACC on the 75th anniversary, preceded the night of the first late breaker. So what a great milestone for the organization. I want to start with Warrior. It kicked off the whole meeting and understandably so. Why? This is an area, ANOCA, ischemia with non-obstructive coronary disease, that really, preferentially affects women, and not many therapies in terms of what to do about it. We know it has a lot of morbidity. So kudos to the investigators for all their hard work in studying this really important group of individuals. And, it was about 2,500 women who had ischemia, but whether on CTA or cath, had no obstructive coronary disease. And the question they're asking is, intensive medical therapy, could that reduce MACE rates? We know that there's a lot of revascularization and coming in with unstable angina. So really looking at statins and ACEs and ARBs. And, one of the challenges back to COVID, I think they were trying to recruit during COVID, made it pretty hard. All told, I think that the answer is it's a neutral trial. I don't want to say a negative trial, but a neutral trial where intensive medical therapy versus usual care did not reduce the risk of major adverse cardiovascular events. Now, on face, that seems a little disappointing. There are some always nuances in studies that, that LDL difference was only about 8 milligrams per deciliter, really no blood pressure difference. So crossover, how intensive was the medical therapy? Are we biasing towards the null? But, it is importantly, one thing is that the thing that dominated here, was patients coming in with unstable angina which tells you about the morbidity. It was really high in terms of morbidity. And I think it really gave us a lot of food for thought in terms of how we might manage these individuals and what might be the next study. So really important from my perspective, but I want to stick with the opening session still. ALPACA was also in there, and I know it's an area where you work. So tell me your thoughts.
Yeah, well, I'll just say one thing about Warrior, which is, it doesn't tell us we shouldn't do intensive therapy. What really tells me, I think, unfortunately, is that this is a high morbidity group that we're going to learn more about. But there wasn't as big a difference in the LDL. So it's hard sometimes because we're taking good care of patients, hopefully, or we're still looking for other therapeutic options. Well, ALPACA, as you mentioned, I'll just say briefly, is a really important study. We've done a lot in the antithrombotic space. We're starting to extend that to populations that are just really important and growing that we don't always talk about. So just to be clear about what ALPACA was, it's an extended reduced dose apixaban versus usual dose apixaban in cancer-associated venous thromboembolism. So these are patients who have active cancer. They have a venous thromboembolism. They're treated for 6 months. And then beyond that, because they have active cancer, there's a question of extension. And a lot of these patients do get extension therapy. And that extension therapy dosing was the question in this randomized trial. And so what they did is at least 6 months of the anticoagulation, they had it, and then they were randomized 1-to-1 to 2.5 milligrams of apixaban twice daily or 5 milligrams of apixaban twice daily. I want to highlight this isn't the atrial fibrillation population. These doses, though, have been studied, as you know, in treatment of DVT-PE, but they've not been they've been studied extensively, but not at this dose change for cancer thromboembolism prevention. So what did they find? I think they got it at least for 12 months, and it's important that it was a pretty big study published in the New England Journal, over 1,700 patients. And as you might imagine, the duration of treatment was about 12 months, as I said. And it was interesting. We assumed potentially that the 2.5 milligram patients might have lower bleeding, and numerically they did. But importantly, they had similar, if not even numerically lower rates of thromboembolism. And I think that's an important finding, meaning that the 2.5 milligram dose in this population does look like not only do they bleed a little bit less, significantly, at least 0.75 for the hazard ratio, but less or at least numerically non-inferior and similar on the venous thromboembolism. So if you're going to extend it in this high-risk population, important population, that would be the dose. I was just going to say one caution is not to do dose reduction or other doses in other indications. So, a lot of times we might think, oh, in atrial fibrillation, they're at risk for bleeding, I'm going to do it. I often say in AFib in clinical practice, do the 2 criteria out of 3, make sure they stay on 5 of apixaban. We see a lot of people getting 2.5, and that may actually increase their stroke rate. We don't want to do that.
Yeah, I think you're spot on there. One is this is really important. We know with the cardio oncology field that survivors and needing extended long-term therapy, reducing bleeding is important. And if we can do that without any penalty on the efficacy side, that's a really important finding. But to your point, we shouldn't extrapolate that to other disease states. This is a specific disease entity. So you and I were talking about the SOUL trial earlier. I mean, how could we not? It's a really important study. I mean, really GLP-1s have dominated the last several rounds of meetings, understandably why. I mean, really a game changer class of drugs. Here's a little bit different because we've really been focused on the injectable forms in the last several meetings. Here we're going back to something that's FDA approved, an oral semaglutide. And I think that, if you look back, there was a prior study, Pioneer 6, where it did show that in patients, it was a non-inferiority trial. So it really wasn't, powered or looking at reduction in cardiovascular events. So this was really more of a dedicated study, specifically looking at more than 9,000 individuals who had type 2 diabetes and either cardiovascular disease or chronic kidney disease. The majority had cardiovascular disease, the minority had solely chronic kidney disease. But a high-risk population and a group where we always are looking for additional therapies and opportunities for prevention. All told, they found a 14% relative risk reduction in MACE, a 2% absolute risk reduction. So number needed to treat about 50. That's clinically important and meaningful in this high-risk group. To me, a couple of kind of subplots here. There's a lot of learnings here. One is that there's a sizable proportion that were on concomitant SGLT2s. They published actually 3 articles at the same time. One was in Circulation looking at that subgroup of on SGLT2 or not, and found that there was no interaction. That's really important because we really don't have great data about using these agents together. And we know that these classes of drugs can both benefit patients with cardiovascular disease and diabetes. So that was an important finding. It was technically null on the secondary endpoint, which included kidney disease. There was a good trend in chronic kidney disease. And again, there was a simultaneous meta-analysis published supporting the benefits. But all told, a modest reduction in cardiovascular disease events. I say, what's the take home here? What's the point? Is that, patients need options. And for whatever reason, that injectable semaglutide and some patients can't tolerate it from a GI perspective here, it was well tolerated, not different than placebo in terms of GI tolerability. And for whatever reason, and I think, the presenter made this point, I mean, the needle's really small, but people are still scared, and so to have an oral opportunity and convincing evidence that it reduces cardiovascular events, I think we just want a broad toolkit for our patients for prevention, but not sure if you had any other thoughts on that.
I agree with almost all the points you said. And I'll just say the big thing for me to take home, one is options are great. Second is, if you could have a little bit better GI tolerability with these agents, you might even have a little bit of uptake. So people want different things. Although I'll just say, having used the agent, the injectables, people eventually get over even if they have it, because there's such a great drive to, 1, get the weight loss, but 2, potentially get the cardiovascular and kidney benefits. So continued revolution in the field of prevention with GLP-1 receptor agonists, now going from injectables to orals. I'll say some of that's going on in the valve thing. I'm going to now switch our focus to some of the stuff we saw.
You are wearing scrubs today, Manesh, so we want to hear about the valve
back home quickly, tried to get sure that I get back into the clinical duties. So I agree, just back to my roots, if you will. But I'll say an important study that was published simultaneously and presented in Lancet called Align AR, AR for aortic regurgitation. And so we've had the revolution of TAVI or TAVR, where we have patients with aortic stenosis that we can do transfemoral transcatheter aortic valve implantation for aortic stenosis, but we have not yet done it for people with isolated aortic regurgitation. And they're really hampered by, I'll call it unacceptable rates of embolization, paravalvular regurgitation, other things like that. So the Align AR was a prospective multi-center single arm study using this new valve called the Trilogy transcatheter valve. And it looked at patients at those centers that were mean age 75, about 85 of the patients in this, and there are overall about 346 patients. About 85 or 47% were female. there was a wide group of sort of significant aortic insufficiency, and these patients actually did really well with getting this valve in the single arm study. Remembering in the valve studies, we do single arm studies and look at defined rates of complications. So 95% of the patients had a technical success. And at 30 days, there were about 2 deaths and 1 disabling stroke. And these were pretty comorbid patients. So I just want to highlight that these are patients that were deemed too high risk for surgery, and these people with a significant aortic insufficiency. So I would say, a step forward, as is often in this technology, is another option, an option for patients with aortic insufficiency, and a way to potentially treat them with a study where it's specifically looking at this group of patients.
Yeah, listen, I couldn't agree more, and we're going to talk more about valves in a bit, but it all starts with TAVR, and then we sort of extend along the different valve spectrum. And before, you're sort of extrapolating, could this work? Would this work? But we both see a lot of patients with aortic insufficiency that have comorbidity, where the surgery they're impacted by the disease, but the surgical risk be prohibitively high. And so it's important to study this in a dedicated fashion. We know that ad hoc this has been happening to some extent, but to have a dedicated fashion with a specific valve for this indication, I think it is a real step forward. And along with many other, again, that we'll talk about in a bit, with advances in the valve field. So couldn't agree more. There isn't a linkage here when we think about linkage to aortic valve disease, aortic stenosis, and lipoprotein A. So there's my segue to something I'd love to talk about for the back to the prevention field. Lipoprotein A is all the rage. You could get yours measured here at the meeting, and there's a good reason. We know that 1 in 5 people have an elevated level and markedly increase the risk for lifetime risk for cardiovascular events, and again, aortic stenosis specifically. There's many therapeutics. There's 5 now, sort of in advanced phase development. One was presented here, the ALPACA trial of a drug called lipodisirin. This is what's really cool about it. Each of these agents in development are a little bit different. So none, and whether it's mechanism, whether it's how it's delivered, et cetera. This is a silencing RNA that, based on sort of the moiety itself, it's given once and at one-time dose. And these were 320 individuals followed for 60 and 180 days. Again, the key here is that just this one-time dosing over 180 days is really, if you think about from a patient adherence perspective, and just an interesting option. I should say their mean lipoprotein A was 253, which is quite high nanomoles per milliliter, nanomoles per liter, which is quite high. At 180 days, at the highest dose, a 400 milligram dose, there was a 94% reduction in LPA, which is pretty astounding. I mean, to have a genetic issue where we currently have no treatments, and to see that level of reduction. I think what's also important in these phase 2 trials is safety. They did not see any concerning safety findings. That's really important. This agent is in phase 3 as well as other agents. So it's really an exciting time in the LPA field to see all these agents sort of one after the other being developed. And again, to our point earlier about SOUL, each one is a little bit different, whether there's an oral version, how often they're delivered, et cetera, different mechanisms of action. So we're going to learn a lot in this field, but it's great to see finally some potential therapeutic options.
It's huge. I think you and others at my institution, others have taught me about the importance of Lp(a). And I'll just say, as an interventionist, these patients I now see back 10 years after they had an early onset MI, and we now are, at least we should have maybe checked Lp(a) before. Now we're doing it not just because we want to explain to them and their family, but their therapy's coming. And I think it's really meaningful for those individuals and for us in a field where we are going to get more and more personalized and identify why individuals have different outcomes. For cardiovascular medicine, I think it's going to be really a big step forward. We hope these therapies can come to market soon. And then as we'll talk about, I'm sure in future episodes, we hope we can get them to all of our patients, because they're obviously important on getting access. Well, look, I mean, we got 2 to go, and I think it's important for us to think about, we went from aorta to Lp(a). I'm going to get us back to the valves. I'm going to go back to tricuspid valve and talk about TRILUMINATE, which I think is an important study that was, again, presented. And one of the reasons I think it's important is it was presented before 1-year follow-up of the TRILUMINATE Pivotal trial using transcatheter edge-to-edge repair for people with severe TR. And the 1-year data importantly showed that there was improved quality of life in those patients with medical therapy and the valve compared to medical therapy alone. but they had similar rates of mortality and heart failure hospitalization. So, one of the conversations was, in prolonged follow-up, will we see different outcomes in these patients? And in fact, they presented and published simultaneously, I think, in Circulation, that these 572 patients that had severe asymptomatic TR were randomized to either tricuspid TR with medical therapy or medical therapy alone. And at 2 years, they looked at, again, recurrent heart failure hospitalizations, mortality, freedom from a bunch of things, including repeat valve surgery, et cetera. I think the big picture was, at 2-year follow-up, importantly, there was a reduction or like lower observed hospitalization in the TIR group compared to control. And I think that's an important finding because it had a hazard ratio about 0.72. And I think, what it tells us is there may be a valve effect with quality of life and then hospitalization following. There was a lot of crossover. So interpreting like getting a repeat valvular surgery is hard for me because there's a lot of crossover in the arm. Mortality rates were similar. And I just talked about hospitalization. So I think a continued evolution, just like we said, having options, but having things we can think about, certainly for these patients with dilated right ventricles, significant TR, and obviously even with medical therapy, potentially these patients will have less symptomatic heart failure formation as they go forward.
Yeah, no, I couldn't agree more with all the comments you made. First, to the point about valves, these are always upfront penalties and procedures. And so the long-term matters, how patients do. We're not looking for short-term benefits in these types of procedures. So this 2-year follow-up data is important. Particularly we think about valve durability, symptoms, what happens in terms of, as you're pointing out, heart failure hospitalization. The one challenge, which I think is the hardest part to dissect, is there's always going to be crossover. There has to be, and other things are going to drop in. So sort of reading the tea leaves of how to interpret this is important. But, more data in a kind of an orphaned valve in the past, but not now squarely in the center of our viewfinder. So really valuable to have these extended data. Manesh, I want to bring it back and maybe finish on something that I think aligns here, which is looking at chronic coronary disease. I think, we think about, 15 million people have chronic coronary artery disease, and it really affects a lot of individuals. And, what we'll talk about is Smart Choice 3. And I say this again, looking at the magnitude of amount of individuals where this comes up. Every day you and I are in clinic, we're taking care of patients that had a PCI, like those in this trial. And then when they've completed their course of dual antiplatelet therapy, we're debating, what drug should we use? And a lot of people have been moving towards clopidogrel. We see that in some of the guidelines, but we really need good data. Is it, aspirin is comfortable to people. It's easy to get, do we know? And so it's not an insignificant decision, just given the magnitude of individuals that are involved here. So, Smart Choice 3, these were about 5,500 individuals who, what's a little bit different, there was a prior study, host exam, which looked at something similar. But what's different here is these were higher risk. And this is what we worry about is, if the thrombotic risk is higher, one is what are we seeing between these two different agents? And then the second part is always, again, looking at a bleeding differential. What's the trade-off? So these individuals, were followed for about 2.3 years. And after they completed their dual antiplatelet therapy, randomized to clopidogrel versus aspirin, a very, again, common clinical question that we see every day. And all told, they saw a 29% reduction in MACE with clopidogrel, and interestingly, not an increased risk of bleeding. I mean, most of the time we see better efficacy, we see more bleeding, but not observed. I will acknowledge, this is in a Korean population where there are different bleeding parameters and stroke risk versus ASCVD, coronary risk. But nevertheless, consistency across these two trials. And I think, for me in my practice, it'll really impact, what we're doing. There's been maybe not as much momentum towards clopidogrel in long term, but given that it's relatively cheap and easy to get now, I think that the data are pretty good now with 2 trials suggesting this is likely the strategy we should think about going forward. But what are your thoughts on that study?
Yeah, look, I think, these are kind of important studies for us, and it makes me think about how do we evolve our medical knowledge faster with guidelines and dogma, if you will. Right. I mean, if you would have said to me, what do I think this is going to show? I would have highly likely said that I think clopidogrel is going to have that. And not just because of intuition. I mean, now 20 years ago, Capri randomized almost 20,000 patients and showed us clopidogrel was better than aspirin in chronic coronary disease. So we have done a PCI in between some of these patients with drug-eluting stents, but, I think we're showing that that's the case. In the Korean population, the only other thought I had was making sure, there's a CYP2C19 metabolism issues in some of our different populations. It may affect some of these, but it's even more encouraging that you see it in that population. So I think it's something that should be adopted as therapies get generic wider. It should be adopted bigger, probably in our practice.
Well, Manesh, I think we covered some of the highlights. There's plenty of other trials we could have covered, but as all things, you leave these meetings kind of inspired, have so much to ruminate on. And we know that, essentially you're back in practice today and I will be tomorrow, and how this is going to change our practice the next day in terms of as we think about patients. That's the whole goal of these trials and these types of studies. So it's been a fantastic meeting. I know I've enjoyed it and learned a lot, and I hope our viewers today learned a lot about the different trials we're able to share with them.
Yeah, thanks for having me. And again, congratulations to the ACC on 75 years and an important meeting to move the field forward.